Hi, my name is Beth Neal. I am a PhD student in the Curriculum and Instruction PhD program at Indiana State University with a concentration in athletic training education and taking ATTR 810 through the Doctorate in Athletic Training program. For the Week 8 module, we had to reflect on our spine evaluation, and it's kind of ironic that we had to do a reflection video on spine because I'm actually teaching the lab class for the master's students within the spine, and it has been a really good refresher throughout this course of being able to go back through and as I go to teach, finding the best evidence-based practice and finding out what current research is saying about some of the techniques that I had learned when I was a student. Kind of going through the articles, I'm going to kind of go through them each separately. For the Canadian C-spine rules, I feel really good about on-field evaluation for C-spine injury. That was my master's thesis, and I've done a lot of extensive research outside of it on C-spine injuries and kind of helping students and teaching them how to know if you should or shouldn't clear a patient to be able to get up or if spine boarding is possible. So that aspect I feel really good about. Once I get somebody into the clinic with a back eval, I don't want to say I dread it, but it's not my favorite eval to do. Even working as a clinician for my 5th year, I really have not seen a large amount of spine injuries, which I'm very surprised about. I expected, especially working women's soccer last year, that I would be seeing a lot more spine or neck injuries, but I really didn't. So I think just the fact that I don't see these often, I'm just very unfamiliar with them and just haven't got the practice or that 10,000 repetitions in to feel better about my spine evals. I did take a class that we went through a lot of these techniques, and so going back through and reading these articles kind of put some of that refresher in, and the McKenzie articles are 2 great examples that I never was introduced to them prior to my last semester of my master's here at ISU, and then jumped into teaching, so haven't really utilized them clinically. But they definitely have a lot of good information that I'm going to be doing the special tests for the master's students actually in 3 weeks here. So I'm excited to utilize those within the back protocol to then teach the students. The whole part of centralization phenomenon to me is still, I get it. It kind of, I feel, goes against a lot of what we teach as athletic trainers. A lot of times we teach that you want to go to the root of the problem and ensure that you are taking care of whatever that is, and then secondarily treating any referred pain, whereas this is kind of opposite of that. And so I'm really excited to use this article, the systematic review that you posted, because this was one of the special tests that I had to be teaching, and so I had this on my to-do list of some extra research that needed to be done. So this kind of was able to help me understand it better, as well as for myself, as well as prepare some future students and ensuring that they know it. Some of the other things that I do or don't do within back evals, I kind of take a more of an approach of like it's very severe or it's not, and I know that that's bad to do. I feel like a lot of times people come in and complain of like things such as like low back pain or muscle pain, and I understand where the anatomy is, know where it is, have taught anatomy lab, and am very good at differentiating muscle types. But then once I get to a person and actually doing the evaluation, I usually just will put like muscle strain or thoracic strain or things like that, and I don't usually get very specific, which I think is detrimental to my patients. So that's going to be something I really want to work on. And then, like I talked about, going through all the special tests again, like I remember them after going through, but a lot of them I could not tell you instantly how to do them. I just think a lot of it's because I haven't been able to practice with it a ton, as I said, but some of it I just think is the fact that there's so many pathologies within the back, and they're all have some overlapping signs and symptoms. I think within what I started talking about, I have been fortunate, or I guess should say knowledgeable enough that I've gotten to the line of when to refer and when not to. So I feel pretty comfortable. I've never like kept a back patient that I was working with that I should not have and misdiagnosed. But maybe that could just be that I lucked out and didn't have anything I kind of missed throughout my time and currently working clinically. there's currently a patient at one of the clinical sites I'm at right now that has a spondylolisthesis, and so I'm hoping I will be around at one of those clinical sites to be able to kind of do some of his rehabilitation here in a month or two when he's allowed to start moving around and regaining that strength. Some other things from the lecture that are within the readings that I read about was a lot of like the radiculopathy rules and going through and understanding exactly what goes on in the C-spine. I think this scares me just because I do have it's such a small area, it's so important, and I feel like I haven't done enough, so I know I've said that a few times about like not trusting myself, but I feel like at that rate, if I was having a lot of cervical issues, I would definitely refer my patient on because I just would not want to miss something that I should be taking care of. I also think that within some of my practice, I am really good at rehabilitation of backs, which I know is probably bad if I don't know that I'm comfortable getting the correct diagnosis, but I've been able to do a lot of combination of core, low back, and back strengthening with some of the patients I've had that were previously diagnosed before I got there. And I think a lot of that just comes down to knowing the body working as a whole in the kinetic chain and knowing that if the trunk isn't working right, then you're going to have dysfunctions all over. And I know last week was a lot of the pelvis area, and that's a lot of where this stems from. But if our patients have additional rotations or muscular imbalances or issues like that, then they will also present with probably a higher risk of like a shoulder injury or potentially a hip or leg injury because of the discrepancies that they see. So I'm really excited to take some of this information and then transfer it down to some of the master's students and be able to help them to understand some of the best clinical and evidence-based practice that is currently out there for the spine.